Chapter 16. Chapter 16, Critical Thinking and Decision Making. This chapter really plays a part of the entire gambit of being an EMS. One of the probably most abstract concepts, yet covers everything, and it's appropriate to fit it in with the assessment section because of the fact that a lot of times in doing our assessments we have to stop, think critically about what potentially could be going on here, determine what have some differential diagnoses, and then make some decisions on what is it exactly we want to do, how we're going to handle and care for this patient. So it's appropriate to include it here in the end of the assessment section with the other two chapters for the week, which help wrap up the section on assessment. We have communications and documentation, and then we will actually start on general pharmacology this week as well. So it fits very well during this week and helps us kind of culminate the assessment paradigm. So when we're talking about patient assessment, a lot of it we really look at trying to be very sequential. We try to drive this into your heads as EMS providers that you have to do this step by step by step by step. And that is very true, that we do want it to be almost robotic-like, to keep us moving in the same manner all the time helps us form our habits. However, it's the information that we glean from that assessment is what goes into our decision-making process. So our objectives, of course, are found on 381, 382 in your textbook. There's just a few short objectives for this chapter. It's a relatively short chapter. Number of multimedia slides for you to take a look at. I would really recommend that you look at these. A lot of good information to kind of touch on the concepts of problem solving. One of the reasons that I like medical emergencies as opposed to trauma emergencies so much is because it's often a puzzle. It's a stop, look at all the information you have, and decide what is our next step. Where do we go from here? So the core concepts we're going to cover is what an EMT diagnosis is. You will hear people say in EMS we don't diagnose, and they are absolutely wrong. We may not call it actually a diagnosis, we call it a field impression, but it's really a diagnosis. If we don't come to a diagnosis, we never know how to treat them. Look at the role of critical thinking in EMS, and then how as an EMT can you improve your critical thinking skills. And this is something you will hone for the remainder of your career, and it's not just EMS, it's everywhere. So we start with EMT diagnosis and critical thinking. So diagnosis is a label for a condition. Now I want to stop for just a second and say we don't always come up with the exact perfect label, or we don't have the pinpointed diagnosis in many cases, but we have some strong feelings that this is what it looks like, walks like, and feels like, so that's what we're going to go under the assumption of. We're going to base our diagnosis off of the history, the physical exam, the vital signs. So we use not only what we see, what we hear, what we gather from information, and we package this all together to come up with what we think is going on. If I say chest pain alone, people may think, oh, well, that's heart. Chest pain is heart. Well, if you stop and you discuss it a little further and you come to find out that the person has been immobile because they've been traveling or they've had a recent injury, they take birth control, they are a smoker, very sedentary lifestyle, and now all of a sudden they have some chest pain and some affiliated shortness of breath, but the chest pain is almost pinpoint, you can almost put a finger on it. Then this starts to lead us down a path going, well, this isn't heart, this is actually something called a pulmonary embolus. So that's how we come to these diagnoses, is when we take all the information and knowing what's what are the vitals, or what are the specific cardinal signs that generally go with a specific condition. That's where we kind of come up with a lot of this info. So, and it involves both physical and intellectual activity. So we have to do a lot of thinking based off the information we gain physically. Here's another problem-solving video for you. So how can we reach this diagnosis? Clinicians often have different levels of training, experience, time, and resources. Obviously, at the EMT level, we're limited on a lot of these things. Training for an EMT is 4, 5, 6 months in most cases, whereas for a physician, they're going to school for 8 years at least, 4 of those for their undergraduate degree, 4 of those in medical school, if not longer. And then they have a couple more learning years during what's called residency, where they are actually working under other physicians and getting their skills honed. So in the grand scheme of things, training-wise, EMTs are on the short end of the stick. Experience, though, there's a lot of very experienced EMTs that do a very good job of coming to some diagnoses and could potentially put some brand new doctors to shame. The time we have with the patient, that's another shortcoming we have. If we're only with the patient on an average of 20 to say 40 minutes, depending on transport times, that's not very much time to get a lot of information. Whereas if a patient is in an inpatient bed in the hospital and the physician comes and sees them 2 or 3 times a day for a week, they have more time to gain information, not to mention use all the other resources that go along with it. And then resources, very limited on our diagnostics. Most places don't have the abilities to do lab work and x-rays, and a lot of the diagnostics that we find in the hospitals, most places don't do that in the ambulance. It's slowly evolving. Even 23 years ago when I started my career, to use a glucometer was fairly uncommon. Not a lot of places carried glucometers to check blood sugars. They had alternative methods that weren't as precise. Pulse oximetry in the last 20 to 30 years is become new and big and bad. Cardiac monitors, 12 lead EKGs. There's all kinds of other different monitors, end-tidal CO2 and carbon monoxide, and lots of different diagnostic tools that we now have available to us because time and technology have helped us. But again, even with the advances that we have, there's still so many more things out there that we just don't have to our disposal to fully and completely come to a specific diagnosis. And then techniques are going to vary based off the type of clinician. EMTs do their assessment in a very specific way. We have a very unique method of doing our patient assessment. And doctors are going to be different, and nurses are going to be different, and even techniques amongst people from different educational backgrounds. Say one person goes to ABC EMT school and another goes to XYZ EMT school, there may be variation there. So a traditional approach to a diagnosis, this is assess the patient, list the conditions of diagnoses, or make the differential diagnoses, further evaluate or reevaluate this differential, and then come up with our final diagnoses. So like I mentioned a little bit ago when I talked about a pulmonary embolus, we gain that information and then we start to cut things down. The number one, I've mentioned this before, the number one call for EMS is shortness of breath, and we could probably list hundreds of causes of shortness of breath. And then upon our assessment of our patient, both gathering the history and doing the physical exam, using any diagnostics that we have, we can then start to whittle down how many potential causes there could be for this. So we might say, well, if the patient has a complaint of shortness of breath, we want to look and see, have you been sick lately? Nope, haven't been sick lately. I was feeling fine right up until the point in which I started to get short of breath. I was feeling great. Well, in those cases, we can go and start to draw lines through pneumonia, probably not pneumonia, if they were fine, absolutely fine up to the point in which they suddenly became short of breath. It wasn't a gradual onset thing. They don't have a fever, so we can say, yeah, those are probably out. We can ask, have you had any recent chest trauma? So no chest trauma. Well, that's going to cut off a few other things that potentially can cause shortness of breath, and so on and so forth. That's how we get to that. So our differential diagnosis is the whole big cloud of potentials, and then through assessment and further reassessment, we start crossing out the less likely. And there are going to be times in which we're wrong. It just happens because patients don't read the textbook. So if we came to a conclusion based off of certain types of signs or symptoms, or certain signs or symptoms that the patient didn't have, it can throw us, and that's okay as long as our treatment in the long run isn't harmful, and our actions aren't harmful. We'll be okay. So our approach to diagnosis: quickly rule out and treat the immediate life threats. Well, that should be fairly easy to do when we do our primary assessment. And remember, the purpose of the primary assessment is to find and treat any life threats. So we're probably not making any diagnoses really in the primary assessment unless it's something like unresponsive apnea, cardiac arrest. We're not going to be very specific on those. We don't know why those things happen. We return and gather additional information. So now, after we've stabilized the A, B, C's, D's, we can now start to gather more information. We can go hunt for scene clues. We can talk to patients, talk to family members, gather our vital signs, do our various diagnostics, do your hands-on exam, find any of the little nuances or intricacies that might be popping up that maybe even the patient didn't even understand or didn't know. Focus on ruling out the worst case scenario. So red flag suggests that the problem is serious. So we want to try to rule out the worst case scenario. But if we can't, then we have to default to the worst case scenario. If it looks like it potentially could be, we should go under the assumption that it probably is. We will treat and transport the patient based off of that worst case scenario, and in the long run we may be proven wrong, but that's okay because we didn't incorrectly treat them. We didn't waste time treating other things that weren't the issue. And then you may be responsible for multiple patients, and if that's the case, it makes the job that much more difficult. And if we're dealing with multiple patients, a lot of times diagnosis kind of gets thrown out. We have let's say a school bus crash, and we may have to deal with 20, 30, 40, 50 students that are injured. The time for spending time coming up with a formal diagnosis gets thrown out because we have sheer overload of the system. And when we overload the system, we're also overloading our personal resources, our minds, our hands, our assessment techniques, and we go into a different mode. Instead of the mode of taking care of one patient, trying to determine what their problem is and treating it, that mode now becomes, let's get multiple patients sorted, which is called triage, sorted and transported to where there are more resources that can help do that formal diagnosis. So as opposed to trying to diagnose each one before we do anything with them. So our approach to it, we got to be very efficient. We need to be available for another call as soon as possible. There are patients that will sit in ERs for the better part of a day or a couple of days. I saw a patient who was in an ER for a week straight. In those cases, they've had lots of time, lots of hands, lots of resources to take care of this patient's problem. But we have to be available for another call as soon as possible. So we can't spend 4 hours with one patient that's 4 blocks from the hospital trying to diagnose them, treat them, and then come up with the various solutions for this problem. We have to do the basics, get them assessed, get them treated, transported, and then we will defer the real detailed diagnosis to the hospital. So we work in an uncontrolled environment, which is we're unique in that setting. Doctors and nurses are not used to being in an upside down car in a ditch in the middle of October when it's freezing rain and 13 degrees outside with no light. It's very different for us than it is compared to other healthcare professionals. So we have a limited tools and skill set, and I mentioned that before. We just don't have all the resources available to us. And then we have a narrower educational focus. We're going to talk about in this class, when we're talking about medical emergencies, trauma emergencies, the more common and life-threatening illnesses and injuries that we see and we run into. We're not going to talk about Crohn's disease. Crohn's disease may be a cause of abdominal pain. We may mention Crohn's disease. We may say that it's an autoimmune disorder, but that's going to be really the end of it. Whereas other healthcare professionals have spent a lot of time learning specifically about Crohn's disease and irritable bowel disease and diverticulitis and diverticulosis and so on and so forth. We can't diagnose a lot of those things in the field. We don't have the capabilities, and most of them are not life-threatening. So we choose to focus on the life-threatening and focus on how do we get this person treated and transported safely, and then we'll defer the further diagnosis. A lot of times we follow the same steps as an emergency physician. Some of ours are very abbreviated or limited. We consider most serious conditions associated with the patient and try to rule them in or out, and we create that differential. So sometimes you might see a phrase placed in a patient's chart, or their run report says, cannot rule out such and such condition. And a lot of times that means I don't think it is this, but I can't say for sure that it's not. So we sometimes will rely on pertinent negatives as well. Say, okay, well, you're complaining of chest pain. Do you have any shortness of breath? No. Are you nauseated? No. Do you have cold sweats? No. Do you have a sense of impending doom, like your life is going to end? No. Well, those are all things that we expect for patients of heart attack or a myocardial infarction. But if they don't have them, they're still pertinent negatives. We're still going to document that the patient says no, 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 because that supports us when we say, well, why didn't you treat that chest pain patient for their heart attack? Well, everything else that was going along with that chest pain complaint wasn't there. So you can reach a diagnosis, but your work is not done. And why is this? Well, just like doctors in the hospital, sometimes we get more information down the road and we have to modify our diagnoses. So we always have a working diagnosis, and this is where we're saying our diagnosis is this, we believe it's this, and we're going to keep assessing and keep doing this, keep doing that, treating this and transporting that. And now all of a sudden, whammo, the patient tells us some little itty-bitty piece of information that we didn't expect, and all of a sudden that changes the whole course. And we're like, whoa, 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 we got to stop this. We're going to go a different angle. So the experienced clinician. Experienced clinicians learn heuristics or shortcuts. And some of those shortcuts include pattern recognition, and it features narrowing possibilities. So what this is saying is your experience will eventually start to change the way you do your assessment, because you'll be able to stop and say, okay, I've had this patient 6 times before, and that patient typically also had this sign or symptom that went along with this complaint and says it is this diagnosis. So those are the sorts of things you pick up on. So as we get into medical emergencies, I encourage you to start comparing what are all the causes of chest pain, what are all the causes of shortness of breath, and picking out the key points in there that kind of tip the scales in one direction or another. This is hard to do. Nothing that I would expect people by the end of their EMT class, which takes 16 weeks, nothing I would expect them to have mastered by the end of that. But it's something that after you've become licensed and now you're honing your craft, you're continuing to become a better EMT, this is the things that you really want to keep in mind. This allows for an efficient diagnosis and a prompt treatment. So sometimes when we learn these shortcuts, and I don't necessarily care for the term shortcut here because it sounds like we're only kind of halfway doing our job, and that's not true. It's just that we've learned that, okay, in general, if they don't complain of this, I can probably skip assessing that and the other thing, or place those in a lower priority and come back and get those later. So it helps us steer our assessment in a certain direction. And it realizes the limitations of shortcuts, understand the common biases of heuristics. Another thing that kind of comes up here is something that we call tunnel vision. Sometimes we get tunnel vision where we start to look at it and say, oh, well, we got called to Joe Blow's house for the 14th time this year for altered mental status. Well, we know Joe Blow is a diabetic. He's always got a low blood sugar because he takes medication and doesn't eat right away, or he's always drinking and he doesn't take his medication, or whatever. And so here we go. Here's time number 15 going to Joe Blow's house for an altered mental status or an unconscious party. He's probably having another diabetic reaction. And then come to find out, we show up and it's not a diabetic action after all. It's the patient has had a seizure. The patient has had a stroke. Something completely different. So it's easy to get stuck in those patterns. So it's always important for us, even though we've been to that patient's house 2, 3, 10, 20 times, to say, this could be the time that is something that I'm not expecting. Another video for you. So how an EMT can learn to think like an experienced physician? Well, first of all, love the ambiguity. Uncertainty is a natural part of EMS. We do not always have all the information. We do not always get all the information. And there are times in which we will pick up a patient, do our assessment, get the history, and then start treatment and transport, get the patient over to the hospital, and then the story that they give the ER is completely different than what they gave us. So one of the great things about EMS is it is always different. We usually have a much different setting, sometimes different partners in a different truck, a different part of town, whatever. So embrace that. Understand that we're going to see differences and we have to be ready for that. Understand understand limitations. People's limitations and technology's limitations. So there are things that we're very, very limited in what we have at our disposal, and so we have to accept that. Now, there are some people who get so overly dependent on some of these technological wizards and wonders that they forget how to do a good assessment. So if the vital signs monitor that's in the truck, maybe we have an automatic blood pressure cuff, isn't working, some people will just be thrown into a complete tizzy because, oh, what am I going to do now? Well, why don't you get out the manual blood pressure cuff and take the blood pressure that way? Oh, yeah, right. So understand limitations. People's limitations as well. We have partners who maybe aren't as experienced that we're going to end up having to run the show. We might be showing up at a place in which they don't understand EMS. And so we have to kind of roll with those punches. If we allow those limitations to control us, we greatly limit what we can do for our patients. So utilize different methods. I recommend that people kind of form a specific system to do things a certain way. But as soon as I say that, I also want you to recognize that sometimes you will find somebody who does something so different and it just works. And if that's the case, it's okay to modify your system. So if you like a particular way that somebody writes a run report, use that. If you like the specific way somebody asks their questions, you can use that. We use these things like sample and decap biddles and AVPU and whatnot simply because they're kind of standardized and they help us remember. But in reality, as long as the same information is being gathered, it really doesn't matter that you specifically use that. There is no one single way that is always right. There's only one hard and fast rule in EMS, and that's that there are no hard and fast rules in EMS. So here's a big one. There's a device that sometimes gets put on a patient. We've talked, I think, very briefly about the vest-style extrication device. It's often called a KED. There are people who will have major arguments over the correct way to put the straps on a KED. There are some people who believe that it has to be one specific order: bottom, middle, top, head, and legs. There are people who believe that that's the only way to do that. And the reality is as long as that patient is secure by the time you're ready to move them, it doesn't matter. Remain open-minded and flexible. There is another public safety service some of you may be involved with that loves their tradition, and when they love their tradition, it sometimes clouds their judgment in being able to accept their future. So there are some people that love to live by this phrase: well, that's not the way we've ever done it. We've always done it this way. That's not being progressive. That's being regressive, and honestly, it's being ignorant. If you're saying this is the only way to do it, it's because that's the only way we've ever done it. There's many cases in which prove that that's not a smart way to go. 1966, when EMS was quote-unquote formally founded, it was because the way we had always done things was we really didn't tell people they needed to wear seat belts. We didn't even put them in cars unless you really, really wanted them. And the way we had always done it is we always had the funeral home come and pick up the injured people and take them to the hospital. Well, obviously EMS worked by changing the way that people thought and said, hey, we should call EMS. Call 911. You call 911, the ambulance comes out, and guess what? They'll do something for you. So you have to be open-minded and flexible. Learn from others. I, after almost a quarter century in EMS, still learn things from newbies in EMS. I watch the way that they do things. I listen to how they do their things. And sometimes I pick things up and I'll add them to my repertoire. Form strong foundation of knowledge. Education is key. What you gain from this class is only the beginning. You're going to start going to continuing education classes to maintain your license. And in order for you to do that, you'll have to sit through some classes. You might have to read some books. You might have to go through some various conferences and seminars. And if that's the case, continue to plug away. Continue to grab those little tidbits of knowledge, those nuggets of knowledge, and stick them in the back of your mind, because they'll come in handy someday. Someday you'll see that patient. You'll go, I remember this from a conference. Be familiar with conditions, and as conditions change, as new things pop up, in the early, or I should say, late 80s, early 90s, there was these conditions that were coming out. They were making people very, very sick, and people were dying, and they were wasting away, and they had no immune system, and the immediate assumption was that it was from either being an IV drug user or a homosexual, but they didn't fully understand what it was. They thought it was some sort of an illness that you got that had absolutely nothing to do with HIV. And then all of a sudden now we have a diagnosis. We've learned more, we've learned more, we've learned more. We've found ways to remain safe. and the hysteria that there was when there was so little information known about HIV and AIDS. They had people losing their mind. So being familiar with new conditions as those come around, at least paying attention to them when the swine flu comes around again, or the bird flu, or the giraffe flu, or the pig, whatever. Just be familiar. Remain up to date. Things change. So many things have changed in 23 years for me. We've done 180s and then flipped right back around again and started doing something that we were told 10 years ago was great, 5 years ago was terrible, and now this year it's great again. So remain up to date and continue your learning. Be organized. When we say be organized, we mean come up with your system. People hate talking, giving the radio report to the hospital. Some people like talking on the radio or talking on the phone, but to give your radio report, your patient report to the hospital that you're bringing in this patient with this problem, people absolutely despise it, and they fumble and stumble all over the place. Well, what they need to keep in mind is if you develop your one system, you always use that system, it becomes natural. You just are able to not even have to think about your report, you're able to spill it. So, be a lifelong student means don't stop learning. Just because you have to have 24 or 20 or 36 or however many hours of continuing ed you end up having to have depending on where you're licensed, doesn't mean that that's all you should take. I know plenty of people who take much, much more continuing education than they're required to. So it's okay to do more. And then reflect on what you've learned. Don't just sit in a conference and gain this information and then get up, walk out, and don't touch on that again. Take a few moments in between classes or at the end of the day, look at your notes that you might have taken and reflect and say, how can I use this? How can I put this into motion? So what are some important things to remember as you learn to make a diagnosis and improve your critical thinking skills? I'll let you guys come up with that one. It's a video on leadership and delegating authority. Those two topics, leadership and delegating authority, you may not initially or early in your career be quote-unquote the leader on the squad, but eventually you will be. Remember that most people are in EMS for about 5 years. So if you stick around EMS very long at all, you work your way up the seniority ladder, and next thing you know, you're the one that has the senior EMT on the squad. You're the one who's going to have to make the decisions. You're the one that everybody looks to and says, now what do we do? And then delegating authority. This can be very difficult depending on the type of personality you have. You may have a hard time asking other people to do things for you. Instead of asking somebody to get a set of vital signs for you while you ask questions and while you try to do an assessment and while you try to put the oxygen on and while you try to start and bag valve the patient. If you can't delegate the authority, if you can't ask people tactfully to do some of these things for you, you quickly find yourself way overwhelmed. If you're the EMT in charge on a call and there's multiple EMTs, you probably should be doing nothing and letting the other EMTs on the call do the hands-on stuff. You're probably the asking questions kind of person. You're the one that's formulating the concepts in your mind, but you're not getting vital signs. You're not putting them on O2. If you have other people do it, let them do it. Now, depending on your crew configuration, there might be only 2 of you on the call, and in those cases, yes, you have to do some of those things. So in review, EMTs make some diagnoses in the field, or diagnoses, although these are not extensive nor as detailed as physician diagnoses. Sometimes, if you've been around this rodeo for very long, you've gained some information, some insight, you can actually make the correct call You come in, you tell the doc, here's what I think's going on. The doc does their quick assessment, and they're like, you're right. That happens. The traditional approach to reaching a diagnosis is to assess the patient, draw up a list of differential diagnoses, or that cloud of possibilities, assess further to rule out or rule in different conditions, and then narrow your list until you reach a conclusion. I like to think of our diagnoses process as starting out as basically being a funnel. At the top of the funnel is very wide open. There's a lot of potential. There could be a lot of things up there. But by the time we get out the bottom side of the funnel, it's been narrowed down so much that it can only be a slim number. And there are still going to be times, though, you're just not going to know. In all my time, my education, my experience, there are still times that I go and I pick up a patient, I transport him to the hospital, and I walk out going, I have no idea what was wrong with that patient. But I was able to assess their signs, symptoms, and treat those appropriately. Highly experienced physicians don't always use a traditional approach. They use heuristics and their experience and training to speed up the process of reaching a diagnosis. It's kind of like, if you want to think about it this way, maybe the very first time that you put together a certain piece of equipment, you probably had to go line by line through the instructions to figure that out. And then you learned it better, and you learned it better, and you learned it better, until finally you got to the point in which you maybe consulted the instructions on one or two things, but for the most part, you just did it because you had it down. Learn to think more critically by accepting ambiguity, understanding limitations, forming strong foundations of knowledge, and organizing data in your mind. If you just have all of these pieces of information floating around up there and you don't try to make any sense of them, all they are is just useless pieces of information because you didn't do anything with what you were given. So we aren't just doing a skill. We're gathering information, compiling it, and then making a decision based off of it. When you consider the cause of the patient's condition, don't let your search for the cause delay the treatment of your patient. This can also be a problem. People will get so stuck on trying to figure out what's wrong, they forgot to really pay any attention to treating what we did find out was going wrong. Critical thinking is an analytical process. It's an organized and efficient way to solve a problem, and it's reflective, reasonable, focused thinking. So we stop, we think, we go back and go, what did we gain? What do we still need to know? If we don't have all the information, we go back and get that information. And we focus it based off of what we do have and what we do know. EMT needs to be efficient yet accurate. Obviously, we're limited on the amount of time we have, and we need to expedite our processes in many cases, so we're available in case there's another call. And patients often have more than one thing wrong. Do not stop looking. You go to a car crash. Well, why did the car crash? I've had this multiple times in my career. You get called to a vehicle collision, and you come to find out, A, there's no damage to the vehicle, so was this really a collision? Or B, the patient fell asleep. The patient had a diabetic reaction. The patient had a seizure. The patient was high on drugs. So it compounds the problems. All right, so your questions to consider. What is a differential diagnosis based on? What is an emergency physician's first priority when formulating a differential? How are heuristics helpful in critical thinking? And how can we as providers enhance our critical thinking and diagnostic skills? So our critical thinking case, a 52-year-old man complains of chest pain while sitting at his desk at work. He appears alert and oriented. He tells you he thinks it just may be stress. How would you arrive at a diagnosis? Well, stress in itself doesn't generally cause chest pain. It could cause some anxiety, could cause a little bit of discomfort, but then we would need to take the remainder of the assessment. look at his vital signs. If he was stressed out, he may have a little bit of an elevated blood pressure. If he was having anxiety, he probably has rapid respirations and a rapid pulse. We would look at his blood pressure. Is blood pressure high or low? We would ask him further questions like, do you have shortness of breath that goes with this? Do you feel nauseated? Do you have sharp pain or dull pain? How bad is the pain? Where does the pain go? Using our OPQRST. So we continue to build upon that. Also knowing that most heart attacks occur when a patient is at rest, not when they're at work, not when they're under physical work. This could very easily be a heart attack. So we would have to take the further information we have, and if we're able to do a 12-lead EKG and so on and so forth, and that is how we would get to our diagnosis.